Good morning and welcome to our monthly webcast. I'm your moderator, Samir Mehta, and this is session number 135. Delighted to have you all join us. Hope everything is getting almost normal post-COVID. I can attest to you that the operations here at Mount Sinai Hospital, and I'll have Dr. Sharma comment on that in a moment, seems to be almost like pre-COVID with the patients coming back, both elective and emergencies, and of course we'll talk about it. We have a very interesting and challenging case for you today. Things what you may be experiencing more and more, all related to TAVR patients. So here is a patient post-TAVR with the long calcified LAD lesion. There are going to be issues. How do you address that? How do you access it post-TAVR, and several other related issues. It's also a procedure we've decided to do trans-radial to keep the interest going and demonstrate to you more of the technical tips as you approach such challenging cases in a trans-radial approach. With this introduction, let me take you to the cardiac catheterization laboratory where Dr. Kinney and Dr. Sharma are right about to start. Samin, good morning. Is my observation correct that volume at the hospital is back to normal?
Well, I mean, life kind of in every way. Coming to normal in New York may not be true in other states and other countries, particularly India, we know, which is having a very high number of cases. But yeah, New York looks like the life is coming back, and what is seen is still that true acute, like STEMIs, those numbers are still down. So whether it's a lead to because of less air pollution or better food or other risk factor modification which people learn during this COVID-19 pandemic, but definitely the patients who were waiting maybe, but otherwise also routine, run-of-the-mill patients are coming because they need a cardiac care. And that is what now, other non-cardiac illnesses are still down. If you take the census as Mount Sinai, other disease processes, admission requirement is still significantly low, but cardiac and cardiology is coming up. With that note, I really thank our viewers to be with us for 10 plus years and 11 years and so now. And this is our 135th episode with myself and Dr. Kinney. Welcome everyone, and Samir, we really thank you to be the great supporter in all these cases, uninterrupted, and be able to moderate with your great knowledge and so. With that note, knowing that this is a new trend nowadays, the patients are coming, they already have a TAVR. Because TAVR is now indicated in low risk, before it was high risk, intermediate and low risk. So more and more patients with a CAD will encounter. Always question comes, what you do when you have a CAD with a TAVR. Overall feeling is that unless it's a significant CAD, you do the TAVR and decide about the CAD later. Or even you need to do CAD PCI. There is a trial ongoing, actually not ongoing, it's in planning phase, will start, called the complete TAVR. That is, patient with a CAD and AS getting a TAVR, and then do you get a PCI or just manage them medically? And this is the same complete trial group who did for STEMI patient. Will be a very interesting trial to show that maybe the prognosis of the patients who have severe aortic stenosis is determined by the success of the TAVR or treatment of AS, not necessarily CAD. They excluded the left main patients in that study group. So that is will be part of it. We have been asked for, and hopefully the trial will take off in next 3 to 6 months. With that note, if we can go to our slides and show this, the recent trend, what is going on. These are our supporters and disclosures as usual. 3 of us, no change. And this is a case number 135, 78-year-old. Now, also in the past, it required that you had to do an angiogram before the TAVR. And that was part of the trials also. But now in the COVID time, everything has changed because patient cannot go multiple times. So we do, unless patient has a known CAD, we try to do angiogram on the same day. And exactly that is what happened for this patient. Patient did not have any CAD before, did have symptoms of exertional dyspnea, little chest pressure, and had a cath on August 7th before the TAVR, and has a severe aortic stenosis, got the SAPIEN valve, and at that time, we did the cath, and of course, if there is a borderline lesion, you need to still identify or really make it that is it physiologically significant. So there were two lesions in this case, RPDA and LAD. We'll show that to you. Normal ejection fraction, and then patient after we did a FFR of the LAD was discharged and continues to have mild angina, was not taking any medicine pre-TAVR. And now the patient is here, and Anu will show that angiogram what we have, and I'll ask the audience and you also that what you think. The right coronary, this is the Akari guide, and you see there is a calcium dystally and a PDA, around 70% lesion. And you, of course, IFR, FFR, a lot of controversy going on. Recent European Society data showed maybe FFR is better than IFR in terms of long-term outcome. But in this PDA, what do you think? The IFR will be positive or negative? Less than 0.89 or above 0.9 and above?
I don't know. My guess would be borderline, probably positive. But borderline would be the...
Yeah, but
okay,
I mean,
show the
IFR.
again.
Yeah, play just to let them everybody see. So the question comes that short lesion, and this is actually IFR 0.95.
Mm-hmm.
So clearly the 0.89 is the cutoff. So basically the key is, so therefore plan was to leave it alone, and let's go to the LAD.
I can tell you if we had given adenosine,
Right.
FFR would have been positive.
Positive,
Yeah.
yeah.
Mm-hmm.
So this is how,
Because-
always after you do the IFR, another picture to make sure that vessel did not change. And now this we have on the left side.
Now, can I make one point on that? What Anu just made, that if you had done the FFR would have been positive. Remember all the sweetheart and defined flare, both the trials comparing IFR and FFR. FFR strategy had about 6 to 7% higher revascularization. So we know that IFR will be negative in about 6% of these patients. So clearly, now whether that translates into a better or worse outcome, right now initial data were equivalent and long-term data are coming, but the key is that yes, IFR where if you take 100 patients, IFR will be positive in about 55, FFR will be positive in about 61, 62.
Anu, was there any challenge in cannulating the left coronary?
No, and this is how the LAD is. You can see a long lesion, calcific, I would say moderate calcium, mid to distal LAD. And actually, if you see the caudal, you will see some moderate disease even after OM2, LPL maybe about diffuse 30% lesion.
A little bridging in the mid portion of the LAD?
Yeah, distal.
Right.
Okay, minus picture. Yes. So I think, but if I had to grade angiographic calcium, you see the tramp track entire LAD. So it is a clearly significant calcium, severe calcium, and we did the IFR, it was 0.79 at the time of the TAVR. So things have not changed after the TAVR in this particular case. Now, there's no need to recross. All these patients get a 30-day echo. So we don't need to recross the valve. Keep it, just to follow them from the echocardiographic point of view in terms of paravalvular leak and so. And usually the valve area you get about 2 centimeter and the velocity is about 0.9 to 1. And there is no paravalvular leak in this particular case on the echo.
Excellent choice, Amin, of this case, I can tell you, because this is being experienced more and more often. What about, was one of the reasons you chose for a trans-radial because of the groins being accessed recently because of the TAVR?
Yeah, so that's another big point, because knowing that one access was large, second one is small, 6 French versus 16 to 17 French. So we just felt that we had not done the radial in a long time, but
right.
One of the reasons which you mentioned that yes, both groins were punctured about a month ago. And so we said that let's try the radial, and actually maybe Dr. Keeney can comment that how easy it was to maneuver and which guide catheter fit in.
It was, we used a VL35, which you see is actually sitting well. We use a short left main, so likely if you see here, just getting into the LAD. Actually, separate origin is into the LAD. So we're now going to go the fielder fine cross to wire it.
Samin,
What about this diagonal? You know, now we are seeing the diagonal a little better.
right.
There is a diagonal disease. We have to think about that.
Samin, how much have you established some kind of a cutoff for a patient, let's say, who's had a TAVR and now you're going back and accessing that groin again?
Yeah, no, I mean, this is again based on how healing has been. And if there is a question, we always want to go to Cotton. Yeah, that we always wait more than 1 month. But 1 month time, the things can heal up. And in this particular case, there was a radial puncture also because of the sentinel device, which was used, but he still has a very good bounding pulse. And if it need to be for the diagonal, which is a moderate size, if something need to be done, you can always go up to the 7 French if you want to decide with a 2-stent strategy.
Which brings us to a topic which at least I'm sure in the structural you talk all the time, but what has been your experience with the Sentinel device?
Yeah, Sentinel actually is very interesting that overall Sentinel is used in about 50-60% of our patients, but a lot of limitation because of the origin of the great vessels and so. But where we used it, clearly it has decreased the overall incidence of major stroke. Some stroke can occur, but minor, and it's only one area which is left vertebral, which is not covered. There are new devices of the cerebral protection are coming, which will basically cover all 3 great vessels, but that part still need to be seen. But Sentinel overall, just like experience with many people, that by doing the Sentinel device, you decrease the overall stroke rate. Even if somebody has a stroke, it's less disabling and they recover fast. So we actually had one recent case, and that patient had kind of became TIA, had the stroke immediately after the with the Sentinel device. And more patients, which we're learning more and more, the patients who have atrial fibrillation, even if you go through the whole strategy of continuing the NOAC or anticoagulation just 2 days before, so those are the patients at very high risk. So Anu, you want to comment on it, that pre-OCT not indicated because?
No, it's a long and a tight lesion. Unlikely we'll be able to get the OCT essentially. You know, you need some dye clearing, and I'm doubtful there'll be dye clearing, especially after the septal. The lesion is significant. So we'll try to do the imaging after we have done the OA.
Okay. So let me just complete the presentation of the case. Sorry.
Yeah, but just to, before you start the presentation, why the decision here to prefer orbital versus, let's say, rotational ablation?
Well, yeah. I mean, it just basically because a lot of people are asking, because we have taught everybody a lot of rotational atherectomy. I think the whole world learned of the rotational. They want to get to the more the orbital, and then actually there is some demand of the laser also. So appropriate case of the laser will use, but orbital just to add to the different technique of the atherectomy. Just that's the reason. But yes, both in this kind of lesion, we do have some selective recommendation for one versus the other in about 20% of cases, but 80% you can use either, and this will be the case where you can use either of them. Orbital or rotational does not make any difference. If we can just show the slide so we can complete the presentation. So this is the patient now planned for post-TAVR, imaging guided complex PCI of the long segmental calcific LAD using orbital atherectomy. Now imaging will be done after the initial atherectomy. So basically 2 vessel disease in this particular case, although now looking at the vessel, even OM has a disease, but if you take it the proximal LAD, and although patient was not on medical therapy, but has a FFR positive, so that becomes significant, and therefore this is what this particular case is. So we are ready with the orbital wire has been advanced, as you can see, and we are ready with the orbital atherectomy now. So basically, this is the motor, which is, they can see it on the top. Yeah, yep. So everything, all controls are right there, and more electric driven, and this is the brake.
2 speed, 80 RPM and 120 RPM, and I think we have been always saying that we try to go only 80 RPM or so. So we saw that the wiper wire is a long lesion. Of course, we could have done a direct wiring, which I did not prefer. We went with fielder fine cross, changed to wiper wire, and I think the picture of the crown, everything has been shown or will be shown how this works. Unlike a rotational atherectomy, which is conical shaped, this has the crown little bit inside. Actually, again, same Calcified. If you download the app Calcified, everything has been nicely described. How the mechanism of functioning of the diamond back as well as rotational atherectomy, how the two devices work, and the principle, the physics principle behind each one of them. So right now we are ready. Since it's radial, question is where you want to keep it. Good.
So brake is the one, activate the motor. So if you're not brake, it will not start. So you have to press the brake and then you check the speed. Same, that machine equipment is working and good. So then you release the brake again and advance.
Just to tell you about radial, if whenever you're doing imaging, you're doing rota or any the OA device, where are you going to keep it? It just here in the gutter. Ready?
Yeah.
Going in.
So push and pull.
Yeah.
So
pull back.
the day, I mean, all these atherectomy devices except the laser are over the wire, long segment. Laser, of course, has a very small monorail.
Can I have this? 1 second. Good.
And both rotational require the long wire, so they have to be careful with the back end. And I always say the back end is always seeking the floor, so make sure it does not make a curl. Make a curl and put a 4x4 there. Yeah.
Low mag.
And push
so
and
you
pull.
can see the guide as well as the distal tip of the wire.
Good.
Okay. Same thing with the 3 steps. Ready?
Guide. You have to advance the guide. Guide is very far away. Good. Yep. That's fine. Well, let's magnify.
Too much.
Yeah.
Go low mag.
Can
It's
they
15.
see? Yeah. Okay.
Okay. Unlike rota, same, this will do sanding when you're going forward as well as backward. Slow pecking motion.
And start pulling back. Yeah. Yeah. It makes a noise at 25 seconds. So you should time it that 20 seconds back and forth, because you have to pull back and stop there. And it does ablation coming back also, which we have emphasized and showed in our Calcified app last month.
You have the balloon ready?
Yeah, we have it.
How is the hemodynamics, Samin?
So
Can you show the hemodynamics?
show the fluoro and the hemodynamics both. Good.
Excellent.
Where's the fluoro?
Hemodynamics look just fine.
You have to put a foot.
Samin, overall, do you think a patient normally does tolerate orbital better than rotational?
Oh yeah, hemodynamics point of view, that is one of the difference which we said. One device will be preferred in a hemodynamic instability. Your orbital will be better, because all the studies of the orbital have shown lower slow flow, because the particles generated are 2 micron compared to rotablation between 2 to 5, and they better, and it's a very high speed jet coming out, so minute particles, short ablation, and eccentric crown never closes the vessel. With the rota, the cone-shaped burr engages the vessel and occludes the flow. While because of eccentricity of the orbital, the flow is always maintained. So minor particles or smaller particles of 2 micron, the continuous flow and high-speed flush, all are responsible, and short ablation runs, all responsible for lower slope flow with the orbital, and that is one of the preference which we said in hemodynamically unstable patient, you'll prefer orbital atherectomy compared to rotational.
There's a question which has just come. How does the Viper wire compare with the Rota wire?
Oh, Viper wire is a much stronger wire. Actually, many times you can deliver your stent and so compared to we say nothing on the Rota wire. And this is a regular Viper 0.012, and then they put a Viper Flex, which is the nitronol wire, which is very flimsy. So I advise to use that wire only in very tortuous and angulated vessels, because that wire we have seen sometimes that it just doesn't give any support. Now you can see here, compared to rotablation, once you're crossed, you have done the ablation. With the orbital, you should do multiple passes, at least 5. And I saw did the 5 passes because the eccentric crown will do the ablation or sending, they call, in a different area of the vessel arc.
You can hold on. You want to go start the...
So now this is also the Dyna assist.
Yeah. Just
glide
press
assist.
glide assist. You press it and now start coming out.
Yeah.
So when you are
Glide
doing...
assist was made to come out of the vessel, but we are using it to come out of the guide also.
Or
Samir,
advance in
when,
the vessel
yeah.
both.
when you're making multiple passes up to 5 using the beneficial orientation of the eccentric crown, are you able to modify the direction of this thing, or it does it by itself?
No, but does it by itself because of the way it will run, because of eccentricity. And secondly, that you can always change the wire position.
Right.
So we always say that in a cases, even rota or so, by changing the wire position, you'll be able to preferentially direct the crown in one way or other. So now, in this case, it's a large vessel. Should you go, because 80,000 RPM will give you lumen of about 1.6, 1.7. That's what it is. If you go to 120, it will give you lumen of about 1.9. Now, question always comes, same. Do you go to 120? We have been teaching everyone that don't go 120 because that's the one associated with perforation. So we'll apply the same strategy what we do for upgrading the bar, rota bar. That basically you leave the... took the wire out?
OCT?
Oh, you do the OCT first,
Yeah.
okay. Because of OCT, otherwise the strategy would be that you leave your orbital wire, you advance your side-by-side wire, and then you dilate with a balloon. And if you see, if you can open it, fine. Otherwise, you can put back the orbital burr and go to 120,000 RPM. But that is rarely needed because this is a very effective device, and it caused multiple deep cuts. We were the first one to write the mechanism in 20 patients comparing orbital versus rotational in the OCT, and really we found that there was a deep cuts were done with the orbital atherectomy. So very effective device in terms of debulking.
So, I mean, 2 follow-up questions, and one of them is, of course, just a corollary to what you just explained. So what would be the cases where you would go with 120?
Yeah, 120, I think it will be same. Vessel size more than 3.5, and maybe if ever used in stent, that may be okay, although it's not indicated. But yes, we are putting our paper also. But yes, 120 would be, if you could not, even in a 4O vessel, I'll go with the 80 and try to open with a lead balloon. If not, then you go to 120. So in my opinion, 120 is a stepped approach in between some other technique. So even in a large vessel, when the 4 millimeter vessel, we go with the 80, dilate with a balloon, and as I mentioned a little bit earlier, that going to 120 is required maybe in a 1 or 2% of cases, just
Now,
because of very effective device.
Obviously, which I think the imaging is going to demonstrate to us, you've ablated well. So why not direct stent here? Why put a balloon?
Good. Very good point. So question is, there are few people proponent of that, that you can directly go after your ablation. You directly go with the stenting. But my question always remains that we do a moderate plaque modification. We are really not doing a debulking. And therefore, I always want to see that your balloon has expanded, because there is still a choice. Now, you do 120, that may be a right approach, that there is no need to do a balloon dilatation and go with the stent directly. But in this particular case, I would basically say that no, you should be able to go, do the balloon, If expanded, of course, the stent. If not expanded, go to 120.
Okay, I'm going to do OCT now.
They need to come up with a newer device or injection technique with a flush or something else. So that really, you know, anytime you inject, you hold your breath.
No, you get chest pain.
I know, we get chest pain or a patient gets V-fib rarely. So we always, one of our nurse always standing at the head end with the pedal ready, although happens very, very rarely.
No, we showed it one of the live case.
Yeah. We happened
And
in one
V-fib.
of, yep. Okay.
Okay.
Tell
Now
us
you
what
can talk case K. Can you hear case K?
Hi.
Yeah, go ahead.
Okay, so this is a reference, go to proximal, and it's like the lesion, this is the lesion, it's like the lipid and like calcium, yeah. 180 calcium.
Yeah, so now you can see exactly where the arrow is, right? This is where the arrow, you see the white arrow? You follow the white arrow.
Connect.
You can see it right now. Nice cuts, right? You can see the cuts?
Yep.
Are you able to appreciate the cuts? Deep cut, and then essentially we're trying to say, yeah,
16,
the calcium is superficial,
18,
some deep calcium.
20.
Yeah, if you see here, this is what we are trying to say.
Yes,
All calcium.
yes.
He's telling.
These are 3.548.
Okay. Again, well demarcated calcium here.
Yeah, synergy, the new one. 3548. Yeah.
Okay.
Go up.
Okay, some OA cuts.
16.
I would say nice work done by OA.
But you can see any decalcification of, it's very tough, right?
No. We don't want, I think we see some not too deep cuts.
Go up.
Do you have the OCT picture of the publication?
Yeah, but no
of the
deep
deep
cuts.
cuts. No, yeah.
Okay. Negative.
We see some ST depressions.
And ST elevations,
Yeah.
which is not uncommon because we are doing LAD PCI. Now
Okay, we can
back.
go show the EKG now.
Yeah. And everybody saw the OCT well?
Extremely nice illustrations, I mean.
Good. Why there is ST?
3548 synergy.
1 second, wait, yeah. Okay.
Did you see the flow?
Yeah, earlier was good.
No,
Now,
let's see the flow
not
again.
after that. Okay, how? We have to disconnect again?
No need. This way.
Yeah. Little varapam.
Okay, we're giving a little bit varapamil. You see some STs.
Yeah, notice it, and the pressure looks to be okay.
Nitride.
But
Good. So essentially no more dye, just flush. And then
absolutely,
pull
I
back a little
believe
blood.
After the balloon, we have not seen anything yet.
Yeah, I want to see a little bit angio.
magic drug nitroprusside.
Can we go to bigger mag?
Yeah.
Oh, no flow? Okay, no. No, hold on, guide. Okay, ready?
Yeah.
There is flow. STs went down.
Good.
Yeah, the flow is good, and
Good.
Also, we like to do auto balloon pump small. So you'd
You
see
understand?
little saline.
Anu, I may
Push.
have missed it. This is after the balloon?
Yeah.
Okay.
Yeah. No, show actually we did not show that.
Yeah,
earlier.
yeah,
While
that's
doing
what
auto, I'm sorry. Yeah. No, yeah, because we are just concentrating on the now here. So this is one
Right.
inflated at 16 atmosphere. So clearly you didn't need to go to a bigger one, and we covered that entire area. And this is where we are now. And the question is, now we have the recent introduction of 48 millimeter stent, and with the synergy, I know others are coming. In India, we actually have Zion's also 48 millimeter, but there are very few here at present, and it's only the synergy available. And this is what we have: Synergy XD 3.5, 48 millimeter. And hopefully one will cover the entire segment of the proximal and mid. Now, if you saw, ostial LAD has some moderate disease. The question is, do we need to cover it with a separate stent? We need to see. This is a 3.5, 48 Synergy XD, 48 millimeter. And post dilatation, we may have to do with the, earlier we opened with a 3.0. We take a 3.5, 30.
What's been your experience with the long Synergy stent?
Actually, it's quite deliverable, right?
Good. Some die. Okay, good. Go up.
Going up.
You have to come up to the ostium. You want to?
No, no, we'll see another view.
Leave it alone.
Yeah, leave it, because if we may need to do circ some other time.
Yeah. Okay, good.
Okay. 14 atmosphere.
Good. See? I don't like Synergy.
Huh?
That little calcium.
No, yeah,
that.
but we know that.
The
question is what have
mid
you do?
portion, huh? The
Yeah.
mid
Yeah,
portion.
down.
You do a post dilatation. So question was, yes, if you would have gone to 120, maybe would not have seen it, but
No.
did we see that still chunk on the OCT in the proximal part of the LAD? Maybe if that is, so they can bring it on the screen.
Okay, right there. Yeah, keys. That's the one keys.
And show the calcium chunk.
Come down, come down, come down.
Yeah.
Come to the mid LED.
Okay.
Yeah, here. This is the one. Yeah.
Right there, right there.
Yeah.
Yeah.
Lot of it's almost circumferential
Yeah,
calcium. Okay.
that's the one.
Let's take this out. Causing ST elevation is still.
Oh,
Right.
nice. Wow. It's like,
Yeah, long stand. We have to be very careful. Guide being pulled in.
okay, now get us a 3.5 high pressure balloon.
Yep, we just opened it.
I think I need a short one.
No, why?
15.
Let's take a picture.
Okay,
to
you want
see where it
30?
is. Wait one thing. Don't open anything yet. Yeah.
Go.
All the branches are there. Septal, diagonal, so yep. All of them. Diagonal was always a little involved, but that's okay. I mean, in this case, you don't want to do too many other things. Guide is a little too far in, which we can pull it out.
I think we are done post dilate and we do OCT.
Okay, good. So while they are doing this post dilatation, let's go to our presentation, right? We can go for a few minutes.
Yes.
This is
Yeah. So let's go to the slides again.
30 length. They already opened. Oh. 3.5 30.
So key is we are going to talk about the two issues in coronary intervention. Recently completed our European Society of Cardiology 2020. I don't know, sorry, the mistake there. These are the various trials which we'll talk about: post-reduced ACS, sweetheart, elderly ACS, dubious, popular cabbage, and reality. So key is that lot of studies done about various platelet strategies. And second, which we always made that focus review of the month, the Taylor PCI trial. So this is what it is. We'll talk about the genomic guided. So basically the 2020 trial. Before I go on to the trial, one of the big issue has been the bleeding. And we did earlier spoke briefly, but just want to say that BARC definition, which actually Roxana Maran came up with these definition points published in Circulation in 2011, made type 1, 2, 3, 4, and 5. And these are the one which clearly describes what they are. Type 1 is the no nuisance bleeding, no need for healthcare worker. Type 2 requires some healthcare assessment. And then type 3, A, B, and C in terms of your hemoglobin drop of 3 to 5, more than 5, or intraocular bleed. And type 4 is the cabbage related bleeding, and type 5 is the fatal bleeding with a definite and probable. So key, those are the definitions are used repeatedly in various trials. So coming back to the first trial, it was the host reduced Polytech ACS trial. It was a open label multi-center trial of two things. One, of two different de-escalation strategy of prasugrel, and secondly, biodurable versus bioabsorbable polymer. So they basically, we are having the data on the de-escalation of the pressure. What was it? Acute coronary syndrome patients, about 2338 were randomized, all got aspirin load and 100 milligram daily, and pressure 60 milligram load and 10 milligram daily for 1 month. After 1 month, these patients were divided. One group, half of them got the de-escalation, that pressure became 5 milligram. These are the patients who had an initial indication of 10 milligram, were not the young age, less than 60 kilo or 75 years of age. These patients were of 10 milligram dose, and others, they continued 10 milligram for 1 year. So what did we find? By the de-escalation, which is in the red bar, you see that significant reduction in NACE, particularly from the bleeding. Major bleeding was lower without any risk of MI or stent thrombosis. So what we learned, that basically de-escalation going to 5 milligram is better. Now, as you know, at Mount Sinai, we have our own protocol. Unless patient is more than 100 kilo or we put more than 3 stents, we give 5 milligram to every patient. After, irrespective of their, the recommendation, we give 5 milligram only to all the patients. Load is still 60 milligram. If somebody is on maintenance antiplatelet therapy of clopidogrel, then we give 30 milligram load. But otherwise, 60 milligram load and 5 milligram daily is the routine at Sinai. So this actually favors that even in acute coronary syndrome, de-escalation at 1 month is appropriate. And they say, you take it, let's say what happened benefit after 1 month. And you can see there that real benefit of the efficacy 1 month, and bleeding significant is the safety endpoint after 1 month. So key is that 1 month, because why? Everybody got 10 milligram for 1 month. So real benefit was by de-escalation after 1 month causing the lower bleeding. So clearly this was in East Asian patients, this was a trial showing that 5 milligram is good enough. Then the elderly patients, this is data from the Swede Heart Registry. We had a data of the popular age which compared ticagrelor versus clopidogrel in favor of clopidogrel. Similar data here in the Swede Heart Registry of the elderly patients. So they actually is a large registry of all the patients in the Sweden, less than 80 years or more than 80 years, and 80 years more than 80 were the part of the trial, which is ticagrelor versus clopidogrel. 40% got ticagrelor. These are all acute coronary syndrome patients. 60% got clopidogrel. And you can see here that red bar versus the blue bar. So if you take stroke, MI, death, and readmission for bleeding, it numerically higher in the clopidogrel group, but then they call it inverse probability treatment weighting, IPTW, adjusted for confidence interval, and you can see confidence interval was just about 1. More importantly, that you have in terms of bleeding is higher with the ticagrelor group compared to clopidogrel group. So this basically, these are the curves, and the conclusion of the trial was that ticagrelor used among elderly MI patients was associated with higher risk of bleeding and death compared with clopidogrel. A randomized study of ticagrelor versus clopidogrel in the elderly is needed. So if I can stop here because they are ready for the OCT. Okay. You want to show that now?
He'll show it right now. I just want to take a final picture. Can you show the OCT? Yeah. With co-registration or no? Okay, good.
I'm interested to see in the proximal to mid segment of the stented area, there looked a little lucency there before on the angiogram.
But what is, this is just what's called as a bird's eye view. As soon as you do the OCT, this is the new software they have. Look at the stent. It shows the stent is
very
well
nice
opposed.
Apposition,
yeah. If there was any issue with the stent opposition, you will see a red color, and you do not see any red color anywhere. You can see maybe a dot here. Look at this one here. One dot here. You see that?
Yeah.
That's it. But let's go into that. And okay, here. Okay, now
This
we'll start from distal edge.
Remarkable
Distal edge.
software functioning, huh? This is very useful.
It talks. Okay, so now if you see here, it start coming here. Well opposed stent. You don't even see the stent start.
Yeah.
So well, I mean.
Beautiful.
Yeah. complete. Nice. Come back. Kiski, you happy?
Yeah, happy, of course.
Okay. Anything you want to tell us?
Yeah, no, perfect. No dissection, no position.
No,
Mm.
Well expanded.
Mm.
Perfect.
Yeah, what about this area? No.
This is the no. This is the
Little
side
bit to the
branch.
left side.
This is side branch. Yeah.
Side branch.
Little bit to the left side. Yeah, here. What are you seeing here? Nothing?
No.
Nothing. Yeah. Of course, with the outside calcium, not the perfect round shape, but the area is like 8.6.
So this is the calcium.
Yeah,
Yeah.
What
so
he's
remember-
saying, lumen area is 8.6. We don't have to worry.
Yeah.
Yeah.
So this is the one, I think that shadow, Samir, you are talking about, that calcium is still protruding through the stent struts in the proximal 1/3 or whatever, 10%, 15% of that stent struts. But otherwise, look at how nicely the stent, 48 millimeter, has taken the shape of the vessel and fully opposed.
Yeah.
No, I think this is a very valuable addition. It gives a beautiful view of the stent apposition. Anu, there is a question which has come, I think, for you, which I'll read exactly as it is stated from Dr. Pawar, I assume from India, but any precautions while engaging coronaries post-TAVI to avoid damage to the struts of the TAVI valve? We kind of talked about it in the beginning, but you want to add any other?
No, not really. I think what we have our TAVR cathode, another app, where we discuss everything about the TAVR valves and how to engage the TAVR valve. I don't know if he's going to show even an animation. There's a beautiful animation that we have made, and we are actually telling how to engage this valve. So much so for the SAPIEN, it's much easier. You saw that. Actually, Amit Huda, our senior most interventional fellow here, is the one who engaged it very nicely. And so you go with the J-tipped wire, and it will be easy to engage with this. There's no worries that you will actually destroy any strut or anything to do with the SAPIEN valve. With actually the Evolute, you just have to be careful that you go with the J wire and get into the lumen and then try to engage. If you have problem, then you can change to the the Terumo wire to engage these catheters. But I think if you have the animation,
We are not here today. This one, yeah.
I can show the animation on the
So bring
app
the
at the end.
animation, we'll show it in the end. The app animation.
And
yeah.
app animation.
So we'll say the tower cathode animation in the end. But yes, this is the disease. I would say not disease. The situation which we have created, that post-tower patients will be coming, and the whole issue, ball game remains for the SAPIEN and the other new valves, the Lotus, because they are all infraannular below the coronary artery, so easy to engage. The issue will be with the Evolute. Although some people claim that there is no difficulty, but we have seen difficulty in those cases, and we are published the paper in terms of what catheter to use in which situation in the JACC paper, which is not part of the discussion today, but we'll show that tower cathode in animation of engaging the coronaries with the various valves. So with that note, we can go back to the slides, please. Let's come back to the slide presentation. Yeah. So the second was, no, but they should bring it on the key. They can bring my laptop. We can do it in the end. We still have a few more minutes. You want to show it on your hand? No, you want to just show on the hand? No, but huh? No, this is not the computer. Yeah, no, this is not the computer. This is not commented. Yeah. You want to show by the hand, this one only? Yeah, but there we have only two views. No, but she can bring my laptop. That's not a problem. Yeah. Okay, so we'll try to get some animation to show. Okay, so clearly we understood that elderly MI patients associated with high risk of bleeding and death compared with clopidogrel. So clearly the ticagrelor, I would say, it may not be the right drug in the elderly patient more than 80. So this becomes really, the choice makes the difference, particularly in the elderly patients and so. So then what is the timing? Remember, this always have been, do you do upstream or do it downstream on the cath table? So this actually looked into various trials, the recent being the dubious trial, giving ticagrelor before or after, and basically showed that whether you give before, downstream or upstream, there was no difference. So clearly our policy that we do it on the table is appropriate and timing. The third trial was using the ticagrelor in the cabbage patient called popular cabbage. That does it make difference in terms of having the graft patency? And you can see here that graft patency was not different with the ticagrelor use, and occlusion patency was no difference, and of course the MACE was not different. So basically showing that the ticagrelor did not work in the post-cabbage setting beyond just aspirin. The one the platelet related trial was the reality trial, and that basically was the strategy of the transfusion after MI and anemia. So whether if you are less than 8 gram hemoglobin or less than 10, do you bring it to 8 to 10 or you bring it more than 11? And that basically showed that restrictive strategy, bringing around 8 to 10 is better than bringing it 11. So key is that we should be happy, our patients, MI patients, having a hemoglobin about 8 to 10 and so. So second issue is our tailored PCI. What is a tailored PCI? So this is about, goes down to genomic testing before PCI. You know, CYP2C19 polymorphism and clopidogrel response. Clopidogrel we know is an inactive drug. It goes into the body and various cytochrome P450 enzymes are involved. Many of them, CYP2C19 is the most important one, and it make it to the active metabolite. So therefore, if shown that many times you don't have this CYP2C19 allele is not available, loss of function, they call it, and that actually happens quite often in the Asians and so. So this, there have been trials in the past to see that if there is a loss of function, you do worse. Many trials have shown. So it seems to be there is higher stent thrombosis, higher rate. So there was a small trial called ADAPT PCI, which incorporated this genomic testing in the cath lab. 252 patients were randomized to genotyping and other for the usual care, and they have a follow-up up to 6 months. So we can do now this genomic testing in the cath lab as a point of care assay, and this is an important point. Spartan RX is a company which do the CYP2C19. Results are available in less than 1 hour. So it's a buccal swab, and therefore you can decide what antiplatelet therapy to use, because if patient is not a carrier, then maybe if they're carrier of CYP2C19, maybe you should go with a stronger antiplatelet drug of ticagrelor or prasugrel, and if they are carriers, then it doesn't matter. So very important, the choice in the cath lab, and this small study showed that genotype versus usual care did not make any difference in terms of bleeding or MACE rate at a month of 7-month follow-up. Now also within that study, they have the groups that if you are no loss of function, that means normal enzyme work, you have the lowest event rate. But if you have a loss of function, use clopidogrel or use a prasugrel, ticagrelor did not make a difference in terms of MACE or the major bleeding. But that led to the multiple recommendation at present, which are very confusing. That basically FDA do say black box warning on the clopidogrel label, the patients that alternate agent should be used who are carriers for the loss of function of that allele CYP2C19, and therefore they say you can do it, but there is no clear-cut guideline from the ACC/AHA that should you use that routinely. So this has been a question, I would say, has been going on for about a decade, and some answer were done by the ADAPT PCI, but really did not answer completely until the latest publication of the tailored PCI randomized trial by Dr. Rihal, which is a multi-center, multinational, global trial, and basically looked at this concept, that effect of genotype guided oral P2Y12 inhibitor selection versus your conventional clopidogrel therapy on ischemic outcomes after PCI. And they use the patient both acute coronary syndrome as well as patient stable CAD. And you can see here on the 2652 large trial of 5,000 plus cases, one was the genotyping and the other one was the conventional strategy. Now, of the eligible patient, you did genotyping, and if you have the loss of function, you're non-carrier, that is not the issue. Issue is that you have to be a carrier of LOF. Those cases were 903. There you want to change the strategy, that you want to use the stronger P2Y12 inhibitor. And compared to in the conventional group, knowing that if you know the beforehand that you are carrier or not carrier, then FDA recommend that you should use the stronger potent P2Y12 agent. So what they did is, in the conventional group, they did the intervention as indicated, but they have a buccal swab, but they analyze only after 12 months. So those patients in the conventional group who were the carrier, LOF carriers, were included in the primary analysis. So you understood that one, prospectively identified patients, which is on the left side, who we modified their therapy. Second group was post hoc analysis of the procedure done as a conventional strategy, but then they tested later on to find out that who were the carriers, and those were compared. So those were the two made the comparison. And if you can see here on the left side, LOF LL carriers and all randomized patients, and overall it seems to be there is no difference in PCR. The overall strategy which was used in terms of the baseline characteristics and primary endpoint. And primary endpoint was cardiovascular death, MI, stroke, or severe recurrent ischemia or stent thrombosis occur in 4% in the genotype guided and conventional 5.9. P-value was trend of 0.06. If you take a recurrent ischemia, P-value was 0.19. Bleeding. Actually, bleeding occurred little more in the genotype guided therapy, 0.08. 3 versus 1.8. So clearly that yes, was slightly lower ischemic event, but slightly higher bleeding event. MI was not different. Only difference was stent thrombosis. You see the stent thrombosis was 0.2 in the genotype guided therapy and 0.9 in the conventional with a p-value of 0.05. So very important. There was no difference in the stroke. So this put into the graph form here. So clearly that what we learned basically is that large trial done, but didn't fail to give us any convincing answer what to do. And this is actually put into the graph form, and so on and so forth. Individual subgroup analysis also did not make any difference. So conclusion and relevance of the study is put very nicely here, that among CYP2C19 loss of function carriers with ACS and stable CAD undergoing PCI, genotype guided selection of an oral P2Y12 inhibitor compared with conventional clopidogrel therapy without point of care genotyping resulted in no statistically significant difference in a composite endpoint of cardiovascular death, MI, stroke, stent thrombosis, and severe recurrent ischemia based on the pre-specified analysis plan and the treatment effect that the study was powered to detect 12 months. And they actually conclude that routine testing of the genotype in the cath lab is not recommended. So clearly whatever guideline we had earlier in 2010 with the ACC are not going to change, because trial did not convincingly show any difference in the acute endpoint. So therefore, very nice editorial by Dr. Moliterno and group. Is it one size rarely fits all? That the future is clearly pointing towards a personalized strategy for therapeutic interventions, and genotype guided approach should be the part of this strategy. The question is how much? And clinical evidence at the critical moment of revamping the healthcare system does not support the routine use of personalized genotype-based selection of antiplatelet therapy for patients with CAD. So that basically conclude this message that we don't worry about the genotype, make your decision clinically, and that is what going to prevail. So take home message, the key interventional trials of 2020, the recent randomized trials and case match registry studies have shown association of a stronger P2Y12 inhibitor compared to reduced dose or clopidogrel with higher bleeding and death rates while minor reduction in ischemic MACE. Therefore, clopidogrel or prasugrel 5 mg or ticagrelor without aspirin will soon become the standard of care treatment post-PCI, especially in elderly patients, in patients with high bleeding risk, and de-escalation is the appropriate strategy. Taylor PCI trial showed the genotype guided selection of an oral P2Y12 inhibitor does not significantly reduce the ischemic endpoint, stent thrombosis or bleeding events. Hence, clinical evidence does not support the routine use of personalized genotype based selection of antiplatelet therapy for ACS or stable CAD. Therefore, decision to use clopidogrel or potent P2Y12 inhibitor should be based on the clinical grounds, considering the patient's bleeding risk and acuity of presentation. And I'll ask Anu to make a comment on it. I know she has been always pro clopidogrel even in the patient with acute coronary syndrome. Yeah.
Yeah, my basis is based on not a randomized clinical trial, but a a single center experience of Dr. Keeney of having treated over 30,000 PCI patients here. That I know incidence is stent thrombosis for acute coronary syndrome patients. For those patients, maybe you can use high potent drugs for maybe a month. What we see is elderly patients as well as even younger patients, the risk of bleeding is very high. What they come and complain to you is that skin bleeds, especially men, that when they're shaving or they have a little scratch, they bleed a lot. So bleeding is a lot, and the GI, I think, upset and bleeding, we see a lot on this patient. That is why I was always for Plavix. In the sense, I would say, in so many years, we've never seen what happens to these patients. Even when we do complex PCI, the outcome was better with Plavix. So if it's working good, as long as we have over between 30 to 50% inhibition, I think it should be good. More than that, definitely gives rise to bleeding in this patient. And we have had a couple of patients with massive intracranial bleed and death because of the DAPT. That itself is something that you need to be very cautious when you use this high potent antiplatelet agents. And the question that was asked by somebody, how to engage these coronary arteries, we have the animation ready. If we can show right now.
We'll show it in the end. Now quickly go to my 3 questions. So coming back to the point, what was the difference then compared to Triton and Plato trial when they compared ticagrelor with clopidogrel or the prasugrel with clopidogrel? Those were the earlier stent. These are the better stent strategies now, and they have a very low stent thrombosis at present. Anyway, coming back to the 3 questions. Following are the true statements from the recent trials for use of potent P2Y12 inhibitor except associated with trend towards MACE, lower MACE, associated with higher bleeding, associated with no significant difference in stent thrombosis, associated with lower death rate, and associated with no difference in stroke. Clearly, the answer is D, that there is no lower death rate with the strategy. Of course, you have bleeding issues. Following are the true statements in the current trends in the use of potent P2Y12 inhibitors except de-escalation to lower dose after 1 to 3 months, continuing aspirin after 1 to 3 months, replacing to clopidogrel after 1 to 3 months, use of clopidogrel in elderly even in ACS, and ticagrelor is not beneficial in post-CABG patients. So what is true basically is that B, which is wrong, continuing aspirin after 1 to 3 months is, we know now in the Twilight and Freedom, Global Freedom, that you can stop it and without any risk of the ischemic event. The last point, the following are the true statement regarding the genotype guided selection of antiplatelet therapy, which is the Taylor PCI, except there was no significant difference in ischemic endpoint, there was no significant difference in cardiovascular death, there was no difference in stent thrombosis, there was no significant difference in major bleeding, there was no significant difference in recurrent ischemia. As you saw, the p-value was 0.05 in favor of lower stent thrombosis in the genotype guided, so that is the wrong answer. So there was a difference, just you can say borderline or so, because of p-value of 0.05. So stent thrombosis did occur lower, but rest of the endpoints were not significant, and that is why it is not a routine strategy at present. Now, Dr. Keeney is ready to show the animation of our TAVR cathode.
Can you show the camera? Where is Danny? Is he on the line? I want to. No, camera is here.
On the laptop? Yeah, camera is there.
They're going to show you. So if you go on the TAVR cathode, right? One news is that we are going to upgrade this TAVR cathode. Whatever the app we have right now, that's going to change. Okay. Essentially, we created this app based on the 2 FDA approved, valves, self-expanding valve and balloon expandable valve. And then what we have it is in the basics, all the explanation about the valve, the coronary height, the height of the valve skirt, the width of the sinus, commissural post, the interplay between the native valve, the native leaflets, and how to select catheters. Everything is explained, and you see the way we like to explain is just very short and point by point. So, very quick explanation. They're just trying to put the things, and the question asked by that physician was very simple, that was it easy? And I already said that if you have our self-expanding the balloon expandable valve, look at it, it's a shorter, so it will be much easier to get into the coronary artery. With the self-expanding valve, your skirt is larger, so you definitely will need a little bit of a cautious to get into. Means you got to be in the center of the valve. Don't go behind the valve and try to engage. There have been cases where the valve has been displaced trying to engage into coronary arteries, so we're just trying to
okay, right here.
get.
Okay.
Yeah, so now this is the valve today we show. Let it play, please. So J wire comes, you see that? We're just trying to show, don't go behind, pull back. So you're in the center there. Now this is your, essentially we're trying to tell you, I think they're showing how to get into the right coronary artery here. But you got to go into the diamond. That's what we are trying to say. So use the J wire and try to get into the diamond and just engage. It's much easier when we are doing it via the for the SAPIEN valve. Okay, just show the evolute valve. This is the right coronary. You have the left coronary artery.
And just show the evolute. That's more
Then
important. Than
show the evolute.
Evolute is more important because that's where you require a little more technical modification, and clearly the most important being the small size catheters. So go with the small, the EBU 2.5, VL30, or even Akari 1.5. You can engage actually both of them, many of these patients. And now evolute is the one which they are trying to show, and this is where we actually have published also commissioner alignment, and now here going to show in engaging the left main and so.
Yeah, it's plain. Okay, now this is the evolute. You see, so now the issue with this valve is very important. You see the cage. Cage is larger. That's what I think Dr. Sharma was mentioning. The catheter size has to be smaller when you're trying to engage. See, this is what we are trying to show. You see that? You have to be very cautious. You have to be in the center of the valve rather than on the side. And then you try to get into one of the diamonds, okay? And find the diamond, then with the wire you get the catheter inside and engage. And when you're coming out, very cautious, use the wire and then come out. Don't just yank the catheter out. The valve could come out with you. So I think we have shown in the animation very well. So when we are upgrading the app, which will be done in the next couple of months, we will have a website as well as an app, and then what we are going to show is how to do PCI. We have animation of how to do PCI through these valves, how to engage the valve guide, how to wire it. Many times what we do is you bring the guide, you leave it at the ostium, means you leave it at the tip of the diamond, and then you will use your glide wire, which is usually fielder, to engage the coronary artery. And then what you will do is engage the coronary artery, and then you will advance guide liner and then try to do the PCI. So all that animation will be, the animations are ready, will be used in our second app right now, which will be coming out to show most of this animation. And of course a lot of upgrade the way you will be able to navigate the current app, as well as website will be the key, that many people keep writing to us that they want a website. And the other thing that I want to announce is that this month we actually released another what we call as a web app called a Complication. The complications that which most of the interventionalists face, how to handle these complications in the cath lab, and that is what this Complicate actually is discussing about. So this is, if you go to cardiologyapps.com, which is our website, and then if you go there, /complicate, you will see what is called as a web app. What is the meaning of a web app? It is actually a website. Why did we make a website? There are 850 angiograms up in this website, and it's not that easy to have it on an app. That's why we made the website. So essentially we made all this groups: atherectomy complications related to acute vessel closure, coronary perforation, bypass graft complication, and longitudinal deformation, and a lot of things that we put it into the miscellaneous. And then if you go down, what we will see is educational content and this case example. Educational content is, you see how we like to teach people, so it's all basis of what is definition of each of these complications, and how to manage this complication is defined in the basics part. And then we have this case selection. Most of the cases are, couple of cases from the live webcast, but all the other cases are the complications that we faced in Mount Sinai. That's what we did it. And we have Gurpreet, come here. Gurpreet was our fellow. He was our research fellow of last year. And he's the one you want to say why you made it and how you want to, what is your vision?
Yeah, so I think, Mount Sinai is one of the busiest cath labs in probably one of in the world as well. And the complication rate is actually among the lowest that you'll find. The area of cases that we have here, extend back to since Dr. Sharma has been practicing and Dr. Kinney's been practicing for over at least 15, 20, 30 years. And we try to include some of the best cases that we can that are actually very complex that you probably won't ever experience in your life. But if you ever did, you actually have seen it before and kind of build on it and grow from it and actually learn how to manage it in a controlled and calm manner. Our vision is actually to train young physicians as well as interventionists like myself and my future colleagues to be leaders like with Dr. Sharma and Dr. Kinney in the future one day, and kind of emulate what they've learned and take the skills that they have and build and grow on that. I think that this is one of the best teaching tools that I've seen so far, along with some of the other apps that we have. But if you really want to grow and be a strong interventional cardiologist, you need to know how to manage these complications to the fullest.
Tell me how you got these cases.
So what we did is actually we went through the database that Dr. Sharma and Dr. Kinney have here at Mount Sinai. We went back to about 2005, where the angiograms were pretty useful with good quality, and we actually filtered through every single case that we had that was listed as a complication, and we reviewed them. We reviewed each case multiple times to make sure that angiograms were adequate for publication on a website. This is done by meticulous work through a lot of people, including Dr. Kinney, Dr. Sharma, a lot of other fellows as well, Bhupati, Sunny, Goyal, and a lot of other people that were there as well. And I think what we ended up doing from there was we had multiple meetings to review these cases on a regular basis. We sat up, and then we had multiple revision people working on the background literature, going through multiple publications and papers to come back with all of what we felt is the adequate way to manage these complications and put it together as a team to make a web page for this.
So essentially our monthly M&M. So what we did was we gave him folders of M&Ms over the last 15 years. We told him go through these cases, and what we think we've then grouped them, and we came up with all the cases, and that's how we came up with this Complicate. And I can tell you, compared to Bifurcate is the #1 liked app from the entire world. I mean, every week to every month, I keep getting emails saying that, how they appreciate that app. But I think as soon as Complicate was released, I know Gurpreet has a lot of friends and Twitter and all this social media work. We probably have the highest exposure has been, and everybody liked it because they are watching, and what they want to learn is if something happens, how to handle it. That's what the interventionists want, and I think this Complicate actually will be the next one, which will probably be in the limelight for the teaching point for all the interventionists, and the younger generation.
And even in the past week, we have like a statistical analysis of what people that are using it. We have over at least a couple thousand unique users already. And this is just beginning so far. It's only been about 10 days since it's been out, and we expect it to grow and grow. And we hopefully we can launch it through ACC in the future. And young physicians that are coming through, cardiologists or anybody that's in the cath lab, cardiac technicians, or anybody that works through this lab should familiarize themselves with how to manage complications, because everybody's really part of the team. It's not just the physicians, it's our techs as well, it's our nurses. And if everybody has a good understanding, that's when you improve patient outcomes.
Okay.
Beautiful.
Yeah.
I mean, this is a phenomenal, extreme work and done, and this is add to the additional teaching which we are poised to do. With that note, I would say that
I have a couple of observations here. First of all, it is. I've been watching this, Anu. I hope you are able to listen in to these comments. They are specifically addressed to you. I've been watching this development of the apps over the last several months and over the last couple of years. And today, for the first time, even I understood the magnitude of it. And I think truly Anu's work, as well as involving all these fellows, Gurpreet's work on the Complication, which I easily can predict to you will be by far the commonest. This is truly remarkable educational addition to the world of interventional cardiology overall. And Samin, just like you mentioned, it provides another arm of the educational purpose of CCC live cases. Going back to two other statements which you and Dr. Kinney made, that all these, and we have had these questions about the dual antiplatelets coming back to us hundreds of times. We've watched it over the beginning of prasugrel, ticagrelor, and today, like Anu just mentioned, that between the two of you having 70,000-80,000 PCIs over 3 decades, I think a personal observation, I think, is such a unique addition to whatever a clinical trial or something will publish with 8,000 patients over 600 sites. Here is a center with the most complex cases and experience. Finally, Samin, to your point, while you were going over one of the trials from the ESC, I have noted that you've always been a proponent of 5 milligrams of prasugrel. So the results never surprised me. You've said it on multiple occasions, and I'm glad it was validated. So those were some of the points I wanted to make. Anu, also I can tell you that the highlight of today's case probably was the visual demonstration, the animation, which is so beautiful. Exactly, how you address the SAPIEN versus the evolute, and the care you have to take. The best point would be that be gentle as you're removing it, be sure the guide wire is there, and of course those are some practical ways not to injure one of the diamonds. With those conclusions, I want to congratulate all of you for a great job. Gurpreet, excellent work with the Complication, and we'll see you during case number 136 on October the 20th.
All right, thank you.
Thank you. Good job, Pablo. Great work.